So this is part two of a two-part webinar. We had part one at the end of January. I think maybe eventually we will have a part three when more people have experience with cluster detection features and maybe more questions and answers, things like that, discussing in greater detail our publications and our findings from each of our papers. But we had part one, part two, and there probably will be a part three sometime in the future, but not this upcoming month. So if you missed part one, I suggest you listen to it at some point, or any of the other webinars. You can find all of the webinars on the WHONET homepage under webinars. These are the past webinars on WHONET and GLASS, macros and reports, multi-drug resistance, cluster detection part one, and today cluster detection part two. For the next webinar, we would like to do the antibiograms, but there's some more programming that we would like to do with regard to the concept of STD, susceptible dose dependent, some other things. So the next webinar may or may not be on the antibiogram. We have other topics listed here, but we very much welcome your input and suggestions for ideas for future webinars. Most of you have probably heard of the WHO GLASS initiative. There's a new initiative called FAO INFARM for the International Food and Resistance Monitoring System from FAO. The website's not quite ready. It's almost there. When that is ready, in collaboration with FAO, we will have a session oriented towards the food and animal health world, as well as anyone interested in a One Health perspective. I'm going to show the website. It is a common question we get, where are the webinars? So if I simply go to whonet.org, I'm here on the main page. I'm here on the home page. In the top, you see webinars. I click on webinars, and you see part two that you're attending is listed here. Underneath that is part one and the other ones that I mentioned. For all of the past webinars, the YouTube recording is there, as well as PowerPoints and sometimes additional resources. So anything which we have covered, including today, you will be able to find later on the WHONET website. I want to go back to my PowerPoint. So today we will start with a brief summary of part one, in part because it was a lot of new concepts for people. So part of it will be a simple review. Part of it, I will introduce some new concepts. Most importantly, the more you hear these terms, I think the easier it will be. So we will start with a summary of some of the key elements of part one. In part one, we discussed basic data preparation and cleaning. Today, we will talk about higher advanced data preparation and cleaning. You will learn how to take a WHONET file and make a smaller WHONET file out of it. We utilize that quite a lot for our cluster detection work. Take all of the isolates, then first isolates in hospitalized patients. We do this as a series of steps. So the ability to create a WHONET file from a WHONET file is very valuable for cluster detection, but it also has other value in other applications. So we will also talk about that. So some of the things that we cover today are of value for cluster detection, but they also have value for other analyses that you may wish to do. We'll then go over some of the analysis parameters, including a demonstration of some of the parameters we discussed in part one. Especially today, I want to discuss this idea of meta groups or meta locations. The idea there is, I showed you last time how to do cluster detection, for example, by medical ward, 5A, 5B, 5C. Neonatal intensive care unit, neurology, oncology. So last time we saw how to do cluster detection by location. Today we will see how to do by location grouping. For example, all of the 5th floor at the same time, all of the intensive care units, all of the university hospitals, all of the hospitals in the north. So we'll see how to take locations and look for clusters, as well as groups of locations. We'll talk about how to interpret those results. And as well as SaTScan analysis options. Okay. So this is the brief review of part one, the webinar that was held at the end of January. How do we find outbreaks? Anecdotal is simply the traditional way. Somebody notices something. A few patients died or became ill with CRE. So anecdotal is traditional cluster detection, where people happen to notice something new is going on. That can be in the community setting, like Salmonella Shigella, with an increase in the number of cases of diarrhea, or it can be in the hospital setting. That's one approach. The second approach is a regular manual review of lab data. I do know many laboratories that do a monthly review. They have a monthly report, and every month they look to see if the numbers are going up or going down. But the focus of today's webinar are using statistical algorithms to improve outbreak detection. There are very simple rules that indeed are too simple, such as 3 MRSA in 1 unit in a 2-week period to trigger cluster mode. Those are very simple rules. But today we will focus on more advanced algorithms. And we especially utilize the SaTScan software, which we introduced during the first webinar. This is a free software, so feel free to download it, and you can use it independently of WHONET. It's used by a number of state health departments, for example. If you are using WHONET, you don't need to learn SaTScan. All of the SaTScan features that you see today are integrated into WHONET. So you will benefit from the use of SaTScan, but you don't actually need to learn SaTScan. WHONET takes care of all of the details automatically. With SaTScan, we can see in red clusters detected by organism species, Klebsiella in the top left, by ward, cardiology, and Staph aureus in the upper right, by resistance profile in the lower left, and also using latitude and longitude, as you can see in the lower right-hand corner. Anything in red is statistically unusual. By the way, I'm in Bangladesh now. I was in Nepal and India last week. So with all the travels and a bit of the smog, I'm having a little bit of a sore throat. So I've got my water bottle here. Okay. So let's see. So, well, that's the end. Is that the end of that? Okay. Now this is back to the review of part 1. Part 1, WHONET and data preparation. As I mentioned last time, there are simple data preparation and more advanced. Whenever we want to analyze data, we need to choose the isolates that we would like to analyze. All isolates, just blood isolates, intensive care unit isolates, only MRSA, inpatient, outpatient. So last time we discussed simple data preparation in one step. For example, I would like all isolates from all species after removing the repeat isolates. In WHONET, you can do that as a simple analysis. You take your original WHONET file, you apply your filter or your filters, and you do the analysis. And we covered that last time. Today, we will see how to do data preparation in multiple steps. For example, at the bottom, the filtering often needs to be accomplished as a series of steps to produce the smaller WHONET file that you would like. For example, you can look at inpatient isolates only, or inpatient isolates on hospital day 3 or later. You can look for CRE or MRSA. You can decide whether or not to include screening isolates. There is value in including screening isolates because in a true outbreak, some patients will get infected with a disease, but other patients will get colonized. They are still part of the outbreak, even if they do not manifest disease. So some people may want to include the screening isolates in their cluster detection. On the other hand, screening practices can change. Some people screen every Monday. Some people screen everyone in the hospital. Some people screen only intensive care unit patients. So with the screening isolates, they can be valuable, but the practices for taking screening isolates, especially if they change over time, can also impact your ability. So in our own studies, we've done a number of cases where we look for clusters, including the screening isolates as part 1 and excluding the screening isolates as part 2. We'll see today how to do this kind of more advanced filtering. Part 1, WHONET demonstration using the default settings and interpretation of the results. I won't do a demonstration right now. I will do that later. But as you saw last time in data analysis, when you go to analysis type, there are 3 analyses highlighted in green where cluster detection is relevant. The first option is called isolate listing and summary. A list of people with MRSA, a list of babies in the neonatal intensive care unit, a list of positive blood isolates, that's a list, and a summary, how many patients. So you can have cluster detection there, as you can see at the bottom, where there are options to include the cluster alerts. The second analysis is called resistance profiles. Instead of just calling the organism Staphylococcus aureus, we can look at organisms that are very resistant to multiple antibiotics, or moderately resistant, or very susceptible. Not all Staph aureus are the same. Also, not all MRSA are the same. They can be quite different. So by utilizing the resistance profile, that improves our sensitivity and specificity in cluster detection. Of course, we would love to have the molecular type, but we're not at the point where molecular type is routinely available. But we do have the resistance pattern, and that is of great value in looking for hospital or community outbreaks. So you see those two options, isolate listing and summary, and resistance profiles. Those are the core of the cluster detection work. The final analysis there is called cluster alerts. It doesn't really do anything different. It's just a repeat of the other two. There are two differences. The other two show you all organisms, all locations, all resistance patterns, irrespective of whether there is a cluster or not. You'll see everything. Some of them will have a cluster. This analysis called cluster alerts, it suppresses anything that doesn't have a cluster. So that's more relevant. If I'm only interested in the clusters, I don't want to see the other organisms. So it's not an analysis difference, it's a formatting difference. You'll only see the organisms or the rooms or the resistance patterns that have a cluster alert. That's one difference. The second difference is the output is a bit more optimized for cluster detection. We have a detailed report, a summary report, and a list of the people involved in a potential cluster. So we will see this later. And as an ongoing reminder, including the name of this webinar, WHONET is not specifically looking for outbreaks. It is looking for statistically significant case clusters. There are more people than you would expect. More people on that day, more people in that month, more people in that room, more people with that resistance pattern. Why are there more people than usual? Well, one interesting reason is there's an outbreak. So definitely we are looking for outbreaks. However, what we are finding is groups of patients that are more than usual. So when you see more patients than usual, it might be an outbreak, but it might be a pseudo outbreak. It might not be an outbreak. It might be that the samples are contaminated or the laboratory materials are contaminated or poor quality. You might see a quote unquote outbreak of imipenem resistant E. coli if you have bad imipenem discs. With a bad imipenem disc, you will end up with false resistance. You can also have changes in sampling practices, changes in test practices. For example, if a laboratory starts to test anaerobes, it will look like you have like an outbreak of anaerobes, but that's not an outbreak. It's just a better detection of something that was there all along. Similarly, if you start to do more screening, you will find more positives, but finding more positive doesn't mean there's more disease. You are just being more aggressive in finding positives. And of course, a lot of people together just might be random variation. Of course, random variation, there is random variation from month to month. Maybe some months have 7 people, 6 people, 8 people. If one month has 12 people, that's higher than normal. It's a little bit higher. So it might be just random variation. So WHONET and SaTScan find very well statistically significant case clusters. Is that a true outbreak or not is it's a different question, but it's an important question. WHONET is very good at finding clusters. If they are true clusters, that's good. If they are all false positives, that's bad. So we'll come back to that at the end of this presentation when we talk about validation and assessment of the results. That's a little bit of the review of the webinar from January. Now we'll talk, I'm sorry, I think this is still part of the review. Yes, this is still part of the review. So last time you saw that in cluster alerts, there are different options. You have the choice between retrospective, prospective, and simulated perspective. We only do the first one and the third one. As we discussed last time, a retrospective analysis answers a valuable question. For example, were there any outbreaks in the year 2023? That's a single question, a single analysis. I do a retrospective analysis to answer the question, were there any clusters last year? Yes, that is an interesting question. However, there's a more interesting question, and that's this third option called simulated perspective. Simulated perspective answers a slightly different question. If we were looking for outbreaks every day last year, what potential outbreaks could we have found? So did we have any potential outbreaks last year on January 1st, January 2nd, January 3rd, May 4th, May 20th, August 7th? So WHONET will march through the year analyzing every single day. So it's also looking at the question, were there clusters in the year 2023, but from the perspective of could we have found these if we had been running WHONET and SaTScan in real time? So this is a more interesting question because it is related to the value of these algorithms in the future. For example, on a monthly basis in the past, how many new clusters did you have? Now today going forward, how many clusters maybe will I expect on a monthly basis? If I expect 30 a month, that might be too many. That's a lot to investigate. If they're 4 a month, that's a more reasonable amount. So we discussed last time you can do retrospective analyses or simulated perspective. There are other options. You can start with the first isolate, last isolate. You can say specific dates that you are more interested in. Then you see maximum cluster length. Maximum cluster length, the name is a little bit misleading. It is not the maximum length of a cluster. It is the maximum length that SaTScan utilizes when looking for clusters. So it might look for clusters of 1 day, 2 day, 3 days in length. At the same time, it also looks for clusters of 7 days, 30 days, 60 days in length. And that's the advantage of SaTScan, is looking for short outbreaks and long outbreaks at the same time. So the maximum cluster length is the maximum length window that SaTScan is considering when it is exploring the question, do we have a cluster in that time frame or not? And I'll show in the next screen what we used to, one of the next screens, the parameters that we used to use. We do not use 100 typically. Here it says baseline data, but it's grayed out. And that's because for retrospective data, you don't need any baseline data. If you want to look for clusters in the year 2023, you only need data from 2023. You don't need data from 2022 because 2023 serves as its own internal comparison population. So for retrospective analysis, there's no need for baseline data. You just need a good time period, like 1 year of complete data. And then you see a p-value threshold. For those of you who are familiar with p-values and statistics, anything with a p-value of 0.05 and higher might be considered just random variation. But if it's 0.05 or lower, that's where we start to think it's a little bit far to be random variation, and it might be statistically unusual, unexpected, for example, an outbreak or a contamination issue. I do have a slide about p-values for people who are not familiar with the concept of p-values. 0.05 simply means 5%, but I'll come back to that on a later slide. Monte Carlo simulations. This does not really impact the statistics very much. It's basically if you're playing, the city of Monte Carlo in Monaco is very famous for gambling. And if you're doing gambling, you can get good statistics if you play a game 1,000 times. You get better statistics if you play it 10,000 times. So what you see here reflects how much statistical work SaTScan is doing to do the statistics. The larger the number, 9999, then the more precise the final estimate will be. And the analysis will go slower. So normally I don't change this, 9999 is fine. However, if you do have a very slow computer, you might want to change this to 999. Doesn't change anything, it's just a is it better to do an experiment 100 times or 1,000 times? Well, either way, the experiment is fine. It will be slower to do it 1,000 times, but you'll also get a more precise answer. And finally, a big subject for today is what is called additional information. And you will see here later that you can put latitude and longitude or groups of locations. For example, the 5th floor or the university hospitals or the Eastern laboratories. So we'll come back to this additional information later today. So these are the set of options for a retrospective analysis. This one is about simulated perspective. Most of the features are the same. But here you do require baseline data. So if I want to look for outbreaks on January 1st, 2023, I do need data from 2022 to serve as the background. if I use 1 year of data. Or if I want to use 2 years of data, I need to go back to January 1st, 2021. So for prospective work, you don't compare January 1st to the time periods after that. You compare it to the time periods before. So for anything prospective or simulated perspective, you give it some baseline data. We used to use 1 year of historical data, and now typically we use 2 years of historical data. But if you don't have 2 years of historical data, then work with 1 year. And if you don't have 1 year of historical data, you might be better off to do a retrospective analysis until you have a full 1 year or 2 years of data. You can also see here, we don't talk anymore about p-values. We talk about recurrence interval, and I will talk about that on a later slide. So p-values, what is a p-value? If you've done this before, this is very easy. If you haven't done it before, don't worry too much about it. Basically, the smaller the p-value, the more interesting the result is. That's the only thing you need to remember. A very small p-value suggests a possible outbreak or a contamination issue. And by a small p-value, I mean anything less than 0.05, less than 0.01, less than 0.0001. A p-value that's very, very small is suggestive of something important going on. For example, an outbreak. So that's the simple message, but here's a little bit more background. For a specific time period, for example, in the month of January, there's an average number of people that we expect to see. Maybe in a month, you are expecting to see 10 people. It's not going to be usually exactly 10 people. Sometimes it'll be 8 people, 11 people, 13 people, 9 people. So the number is going to go up and down around the expected average. If it goes up and down a little bit, that is consistent with random variation. But sometimes the number of people is much higher than you would expect or much lower than you would expect. And that could be random variation. The average might be 10, but once in a while, it might randomly go up to 16 people in a month. So when the numbers go up very high, that could just be random variation. If the data are normally distributed, which often they are not, but if the data are normally distributed, then we expect that the number of patients should be beyond 2 standard deviations above the mean around 5% of the time. For example, here in the green arrow, the average is here at 0. But here above the green arrow, we are more than 2 standard deviations above the average. Yes, that could be random variation. That kind of extreme variation happens less than 5% of the time. And that's why we say 0.05. 0.05 means 5%. But if it's that far away, maybe it isn't random variation. Maybe it's an outbreak. So when a p-value is very small, when we are very far from the expectation, that could be random variation, or it could be an outbreak. And the further away it is from the average, the more we think that it's not random variation. We're never 100% sure, but the smaller the p-value, the higher the statistical significance, and the more likely it is that something is happening besides random variation. So the p-value is an estimate of the probability of seeing this number of people through random variation alone. If the p-value is below 0.05, we're going to call it a possible outbreak. If it's above 0.05, we're going to say it's consistent with random variation. So if we perform a single WHONET-SaTScan and retrospective analysis, we use a p-value for the reasons I just said. It's a single experiment. 5% of the time, you will end up with an extreme result. So if the focus is on a single experiment, if the p-value is greater than 0.05, we make the traditional conclusion that the number of people is consistent with random variation. We might be wrong. It might be an outbreak, but the outbreak might not be very statistically significant, and it might be within the range of normal variation. The basic message is we're never 100% sure. Something that we say is not an outbreak might be an outbreak. Something that we say is an outbreak might not be an outbreak. It might be a contamination issue, but it also just might be random variation. So if the p-value is less than or equal to 0.05, we make the traditional conclusion that the number of people is not consistent with random variation, but we might be wrong. It might be random variation of an extreme nature. So for purposes of publication, a threshold of 0.05 is traditional, but you can use a higher or lower threshold if you wish. If you choose a higher threshold, like a p of 0.1, you'll probably do a better job of finding true outbreaks. We call that improving sensitivity. You're finding the true things that you want, but you have the risk of a higher number of false positives. and we call that worse specificity. So if you have a very loose threshold like 0.1, you will probably pick up more true outbreaks, which is great, but you'll probably also pick up more random variation. And what you will see are positives, but you're unsure whether they're true positives or false positives. And it's also useful to keep in mind that for publications, we use 0.05. It's traditional. But our goal in our hospitals and our communities is not publications, it's saving lives. So if the p-value is 0.06, I'm not going to ignore it. It might be a small outbreak that's just starting. So you might even think about having a different threshold. If it's 0.02, I will investigate. If it's 0.06, it's good information to know. Maybe I'll take a closer look at the data, or maybe I will just watch and wait. So a p-value threshold of 0.05 is traditional, but it's not a magic number. So now I'll talk about a similar concept called recurrence intervals. So a p-value threshold is appropriate for single retrospective analysis. That's with classical traditional statistics that many of you have studied. However, for simulated prospective analyses, we run individual prospective analyses over many days consecutively. Did we have an outbreak on January 1st, on January 2nd, on January 3rd? At the end of the year, WHONET will run SaTScan 365 times. And the problem is if we use the threshold of 0.05, 0.05, 5%, 5% is one time out of 20. So if you're doing an analysis every day, it would be sort of expected that you see something statistically unusual at the 0.05 level every 20 days. But if you're seeing something unusual every 20 days, it's really not that unusual. So when we talk about simulated prospective analyses, you could talk about p-values, but it does get confusing because people are so used to using a 0.05. But 0.05 was always intended for a single experiment. But if you're looking for clusters every day, you don't want to cluster every 20 days, 5% of the time. So what we do instead of talking about the p-value, we talk about its inverse. The inverse means 1 divided by that value. So 1 divided by 0.05 is 20. So when I say a p-value of 0.05, that means your recurrence interval of 20 days. So that's also a nice measure that's easier to explain to people. It's hard to explain to non-experts what a p-value is, but it's easy to explain to somebody, oh, this is a once a month kind of event. This is a once a year kind of event. So recurrence interval is also easier to explain to people. So for cluster detection, we are not interested in events that could easily happen randomly every 20 days. We might be interested in events that happen once a year, like a recurrence interval of 365. It's like a once a year event, or once a 2-year event, once a 5-year event. So 1 divided by 365 is 0.00274. So a recurrence interval of 365 means the same thing as a p-value of 0.00274. So for our publications, that's what we usually use, is a cutoff point of 365 days. But if this is my hospital, I might want a lower threshold, like 90 days. If I see an event like once every 3 months, yes, that could be random variation, and there's no need for me to take any action. On the other hand, it might be a small cluster. It might be the beginning of a cluster. So I don't necessarily say I will respond, but it's just a nice notification. You have something going on here. If it's the neonatal intensive care unit, I will be more interested. If it's a recurrence interval of 100 with CRE, I'll be very interested. So there's not, again, a precise threshold. It's a question of what action do you want to take. And you could set different thresholds for different actions. For example, if the recurrence interval is relatively low, 90 to 180, you might just want to take a quick look at the electronic data. Say, yeah, it's CRE, I want to investigate. It's the babies, I want to investigate. It's susceptible E. coli on adult medical unit. They might say, well, it's interesting, but susceptible E. coli are also very common. So you might just watch and wait to see if it grows bigger. On the other hand, if the recurrence interval is over 365, or if the recurrence interval is over 1,000, you might want to look into the diagnoses and the risk factors and the surgeries, and you might want to send some isolates out for molecular typing. So in publication, it's basically we say it is statistically significant or it isn't. But in a hospital, we don't have to be so strict. We don't have to be so black and white about it. We can say, if it's a little bit statistically significant, I want to know. Maybe I will respond and maybe I won't. So just regarding today's presentation, all of the data I show you today is only using 1 year of data. I'm sorry, what I'm showing you is only using 1 month of data. So everything you see today, they're not exactly real p-values or real recurrence interval rules. They are, I mean, statistically they are accurate, but it's only 1 month of data. In real work, I would never look for outbreaks using only 1 month of data. I would always use at least 1 year of data, or if I have it, then 2 years of data. So for this presentation, we are only using 1 month of the free WHONET data that all of you have when you install WHONET. The reason I use this file, well, is one, I cannot share confidential data from my hospital with you. But a more important reason is everything I do in this presentation, you can repeat yourselves later. Okay? So it's just a good way to reinforce that everything I'm showing you, you can do yourself. So I showed last time this slide. So for many years, many master degree theses, many publications, we always used simulated prospective analysis using the SaTScan space-time permutation model. For our work in Argentina with Salmonella and Shigella for community outbreaks, we used a window of 30 days. Our view is that if you don't know in 30 days if you have a Salmonella outbreak, you probably don't, or you don't have a big one that I would like to optimize my algorithm for. So for our community outbreaks, we use 30 days. For our hospital outbreaks, we use 60 days. Because sometimes the numbers in the hospital are so small, at the end of 30 days, sometimes you're still not sure if it's an outbreak or not. So you might want to wait until 60 days. And we used 1 year of historical data with a publication threshold of 365. But then we started a project with the CDC with 80 US hospitals for automated daily prospective outbreak detection. We found trouble with the space-time permutation. There were some small, important outbreaks of MRSA in some neonatal intensive care units that space-time permutation was not finding. So at the beginning of our work with the CDC, we switched over to space-time uniform. We never applied it for community, so we never changed that. But for our hospital work, we now use a length of 180 days. But I don't want to say that's the correct number. Maybe 90 days is sufficient. The truth is, it makes a difference, but it often doesn't make a big difference. And I will talk about that in one of my last slides about parameter optimization. So we don't know what the best set of parameters are, but we're trying different things out to see what works best for us in our hospitals. But yours will be different given the size of the hospitals, the resistance issues, sampling rates. We also switched from using 1 year of historical data to 2 years. For an organism like E. coli and Staph aureus and Klebsiella, it probably does not really matter very much. But for infrequent organisms, then 2 years of data obviously gives the statistical software more to work with and to evaluate statistical significance. And for publications, we still use a threshold of 365. So I'm now going to do a demonstration, also taking a look at the time to see how we are doing. I'm going to show 4 examples. This is basically going to be a repeat from part 1. After I do this, I'm going to start making some revisions to make sure that we cover some new concepts. So example 1 is cluster detection by organism, and I'll choose all organisms. So leave my PowerPoint. We'll start WHONET. And Adam, anything now? I'm all set just to continue.
Go ahead, John.
Okay, great, thank you. And thanks for monitoring the chat, of course. Okay, where's my WHONET? Okay. So for purposes of today's demonstration, I will choose, as always, the WHO test laboratory. I can, as other people know, I can change it to Spanish, French, Chinese, so there are many languages here. I can do new laboratory for data entry or data analysis, modify laboratory to review the details, but I'll just do a normal open laboratory. And now I'm ready for data entry or data analysis. So I'll go to data analysis. There's quick analysis. That was the subject of another webinar for predefined automated analyses, which is great if you want automated daily, automated monthly reports. We'll come back to that later today. But I'm going to start with interactive analysis where you are in control. You choose the organisms, you choose the parameters, you choose the filters. So analysis type, the 3 questions on the left are required. Analysis type, I will start with isolate, listing, and summary. I want to see my cluster alerts. I want to see my microbiology alerts at the bottom of the screen. And I would like to see my cluster alerts at the lower right. So the isolate alerts are about individual important findings. The cluster alerts is about the possible outbreak detection. Adam, so for many years, I have always called this isolate alerts. We're in the process of renaming this as microbiological alerts. So Adam, if you can note, let's try to change isolate to alerts. Sorry.
Okay.
Sorry, a little water. One of the reasons for doing that is for automatic translations. When we asked for an automatic translation of isolate alerts, the automatic translator thought it was isolate alerts, so the translations were incorrect. I think microbiological alerts will translate better. Plus, I think it's also the concept is easier to understand. Okay, great. So I'm only showing you 1 month of data. So I don't want to show you organism by month. I'll show you organism by day. That will have 0 impact on what SaTScan does. SaTScan, it does not matter what I choose here. SaTScan is always by day, the way that we have set it up. But the graph will be more interesting. So I changed this to make the graph more interesting. So I want isolate, listing, and summary with isolate alerts and with cluster alerts. And I want organism by day. We'll click on OK. Well, okay, the first time I do this, I don't want to do the cluster alerts. I will come back to that. We'll say OK. Organisms, let me choose all. To do that, I can go to organism groups. I can double click on all. Options on the left, selections on the right. Data files. I'll choose this 1 month of sample data that all of you have. It comes with WHONET. I click on OK. And when I'm looking for outbreaks, I do want to be careful about repeat isolates. I'm going to go to 1 per patient. If 1 patient has E. coli 5 times, that's not an outbreak, that's a sick person. So what we do is we can do by isolate, first isolate only, first isolate with antibiotic results, or I can do by time interval or by resistance pattern. So for most of our work, we have done the first isolate in a 365-day window. So if the patient had E. coli 2 months ago, I'll choose the one from 2 months ago. If the patient had E. coli 5 years ago, then I want to focus, I'll use the one from 5 years ago if that's the time period I'm looking at, but I will also use the most recent one. This is the way that our group in Boston has done the analyses. Our collaborators in Japan that we closely collaborate with, they also do the resistance phenotype to say, well, and the advantage of this, it can show you the patient's different kinds of MRSA based on different phenotypes. So we might explore that in our Boston group, but so far our publications have been with the settings that you see here. I'll click on OK. So that removes the first isolate per patient per species. And I will begin the analysis. This is without cluster alerts. So I do see my isolate alerts. So if I go down, some of these boxes will be in red. So those are the isolate alerts that were presented back, I think, in maybe October or November. So those are isolate microbiological alerts. That's not the subject of today's webinar. I'll click on continue, and now I will see the summary. So for example, I'm looking at the graph for Achromobacter, Acinetobacter, etc. And one of the organisms here is diphtheroids, in other words, Corynebacterium species. And I did not ask for cluster alerts. It's just showing me the pure data. And it is noteworthy that there's so many on January 25th. That's interesting. I'm going to click on continue. Oh, let me look at the graph for E. coli. And there's E. coli almost every day, not surprise. And click on continue. Analysis type. Now I will turn on the cluster alerts. I'm also going to turn off the listing. I don't need to see the listing. Every time I look at it, it's going to be the same listing. So for today, I just want to see the summary. Click OK. I click on Begin Analysis. It shows me directly the summary. And I'm going to click on the column called Cluster Number once and once again. Adam, just one thing I thought about. We always sort it in ascending order from large to small to large. We might want to change the default because typically you want the biggest number at the top. So let's discuss that later, changing the default sort sequence. Okay. So out of all of the organisms, only 2 of them have a statistically significant cluster. So all of these other organisms, no comment, no comment, no comment, but the diphtheroids, there is that comment, those red bars on January 25th. There were 7 people. There's a column called number observed. There were 7 people on January 25th. If everything were a simple average, we only really would have expected 1 person. So instead of 1 person, we have 7. That's highly statistically significant with a p-value of 0.0076. As I described on the last webinar, I don't think that's an outbreak. Corynebacterium does not cause a lot of significant disease, but it does cause a lot of contaminations. So one of the reasons I don't think this is a true outbreak is this organism is not commonly associated with outbreaks, but it is associated with contaminations. The other reason I think it's a contamination is it's 7 people on the same day. If there's a true outbreak, usually not everybody gets sick and diagnosed on the same day. Could this be an outbreak? Yes, it could be. I don't want to say it is a contamination issue, but as I look at it, I definitely want to investigate this. I don't think it's a disease outbreak, but I think there's a quality issue. If the samples are getting contaminated, if the laboratory reagents are contaminated, that's a quality of care issue. So even if the explanation for the red bars is not an outbreak, it's still interesting if there's a potential quality issue. So that's one organism that is statistically significant. I will now go to Klebsiella pneumonia. This one looks more like a true outbreak. There were 2 people, and then 3 people, and then 5 people. There were 10 people, and you can see that here in the table. There were 10 people in a 3-day period, January 28th until January 30th. The average would have been around 2.3 people, so we're still a lot higher than normal. And the p-value is 0.02. So we have those 2 clusters. And the other ones, I'm not saying there's no outbreak, but I am saying that they did not reach statistical significance. So this is cluster detection by organism. I'm going to click on Continue. Analysis type. Last time, we did not spend much time with the options. I will now go into the options. And here you will see the p-value is 0.05. But what happens if I change the p-value to 0.2? I'm going to click on OK, click on Begin Analysis. Cluster number, and now I have 3 clusters. Diphtheroids, no change. Klebsiella pneumonia, no change. But there's one new one, Providencia stewardii. And here we have 1 month of data with 2 patients with Providencia stewardii, and both of them were on the same day. I'd be a little worried about that. Were they in the same room? Did they have the same resistance pattern? What was the specimen type? What was the p-value? The p-value is 0.07. That's why we did not see it before, because it was not below 0.05. But 0.07 is pretty close. I've only given you 1 month of data, so I would not say I would jump on this like it's a big outbreak, but I would investigate it a little bit further, at least to see whether it was the same room, to see are these community infections or hospital infections. So by adjusting the thresholds, that does not change what SaTScan does, but it does change what WHONET decides to show you. Okay, great. I'm going to click on Continue. Another feature that I want to talk a little bit more about this time under Options is the simulated perspective. I'm going to start with the default here of 365. And I'm using 365 days of background data. Of course, I don't actually have any background data. It's only 1 month of sample data, but WHONET does not know that. WHONET thinks it's just 0 data, that there were no findings. Okay. So that's a second change. Now that the first analysis I showed you was retrospective, now I'm going to show you simulated prospective, and look in the lower left-hand corner of the screen. When I click on Begin Analysis, it's looking for outbreaks on January 1st, January 10th, January 25th, January 30th. It now finished. It looked for clusters on many, many different days. And it still found the diphtheroids, and it still found the Klebsiella. So it's still, when you do it this way, it doesn't bring you the red colors. I can show you a different way to get the red back. But the numbers in the graph are still showing me the same two clusters. The difference is that the first time, January served as the full time period. All comparisons were with regard to the January data. The second time, it compared with the historical data. For example, for January 25th, it looked at the data before that. So both analyses did show me the same clusters, but their assumptions were a bit different, what it was comparing against. Okay, great. So I think that's the end of example number 1. Example number 2, I'm going to come back to this later, by location. And I'm just going to choose a single organism. And before I do that, just a constant reminder, WHONET macros are very valuable. Here at the bottom, I'm going to click on macros, and we did have a webinar about this. I want to make a new macro. I'm going to say cluster detection by microbial species or by organism. So this allows me to repeat this anytime later very easily and quickly. So anything I think I might want to do again, I make a macro out of it. That's an example number 1. Example number 2, let me change this to location. So I'm going to location by day. That's the only change. And let me go back and put retrospective. I'll come back and do simulated perspective again later when we get to the cluster analysis option. Retrospective, okay. And now I don't want to do all organisms. I just want to do one organism, Staphylococcus aureus, okay? Begin analysis. And here I see the graph for outpatient. I see all my different graphs, but only one of the graphs that you can see in the table has a statistically significant cluster, which is cardiology. You can see there were 3 patients on January 18th, 2 patients on January 19th. That's 5 people in 2 days, which is more than the rest of the month. So that we found clusters for Staph aureus in cardiology. I'm going to click on continue. And I'm going to say this is a macro, new macro, cluster detection by ward, Staph aureus. I'll just put the code SAU. No, Staph aureus is fine. Save, save. The next one is by, the example number 3 is by resistance pattern. I can go to resistance profile analysis. Resistance profile is my row variable. I'd like to do this by day again. And I'd like to include the alerts, the cluster alerts. Okay, Staph aureus is fine. Begin analysis. Here you see the multi-drug resistance patterns. We discussed this back on another webinar about multi-drug resistance. So these Staph aureus are susceptible to everything. These are resistant to one drug, erythromycin. These are resistant to one drug, penicillin, resistant to 2, resistant to 3. At the bottom, these are resistant to all 7 drugs. If you look at the location, 2 of them were oncology. So it's not a surprise to have multi-resistant Staphylococcus aureus in oncology. This is the listing. When I go to continue, one of these has a statistic, in fact, 2 of them have a statistically significant cluster. We have 4 people on the same day with Staphylococcus aureus and erythromycin resistance alone. The p-value is 0.0007. There's another one, which is a p-value of 0.07. So it is not below 0.05. It's a little bit above. And here you can see in 1 month of data, we only had this twice. We had it on January 29th and again on January 30th. That's unusual. It's not below 0.05, but it's just 1 day apart. I wonder if they're in the same room. And you can do a different analysis for that, or you can look at the listing. So it's not significant at the 0.05 level, but it is significant at the 0.1 level for the p-value. And I think I had one more example. So we did organism, location, resistance profile, and location plus resistance profile. Analysis type, and I can do resistance profile, and I can do location. Okay, and begin analysis. And I'll just go direct to the summary. The listing did not change. And here we have some clusters. So one of the clusters is this one here. There were 4 people on the same day with erythromycin-resistant Staphylococcus aureus, but 3 of them were the emergency room. And the other one I remember was the intensive care unit. So not only did they have the same resistance pattern, they also have the same room. Whenever you have the same room and the same resistance pattern, that's of course going to be of great interest to infection control staff. The other one is in cardiology, and it's this one here. So in 1 month of data, there were only these people in cardiology with Staphylococcus aureus that were resistant to 2 drugs, penicillin and erythromycin. Most of the month had none, but then we had 2 on January 18th, 1 on January 19th. This might be a true outbreak. If it is a true outbreak, it is possible it started on the 16th. SaTScan doesn't know when the outbreak started and end. SaTScan is only looking at when it's statistically significant. So if this were a true outbreak, I'd still want to investigate this one here on the 16th. So this is back to my PowerPoint. So that is detecting by organism, location, resistance profile, and the combination. Continue. And now I'm going to go back and go to this last option called cluster alerts. So the rest of today, we'll probably be focusing just in this area. So it's very similar to the other ones, but it's simply going to hide the locations and organisms that don't have a cluster associated with them. So let me do day here. And options, I'm going to click here on options. And I see retrospective. I'm going to start with retrospective. I'm going to click on OK, and begin analysis. And I do have to, it still says organism. Let me do that last example. Let me put location and resistance profile. Resistance profile is not obvious. It's at the very bottom of the list. So variable number 1 is the location. Variable number 2 is resistance profile. I will click on OK. I will click on begin analysis. And it's those same 2 that I just showed you. As I said, that's the only difference. When you do this analysis with isolate listing or resistance profile, it shows you all of the locations, all the resistance patterns. Here it's not showing me all of them. It is only showing me the 2 rows that were statistically significant. WHONET at the present time is not smart enough to draw the graph for this. So this is cardiology, penicillin, erythromycin resistance. There should be a graph, but we have not yet done the programming to make the graph. There are ways to do the graph manually, but we are not yet able to do the graph automatically. Good. This would be a good time to, that was sheet number 1, the detailed report. This is sheet number 2, the summary report. This is sheet number 3, these are the people. So cluster 1 had 5 people. Look at the location, all 5 of them were cardiology. Look at the resistance pattern. Resistant to 2 drugs, penicillin, erythromycin resistance. In fact, you can also see the zone diameters off at the right. That's cluster number 1, cardiology, resistant to 2 drugs. The second cluster is emergency room. And again, if you go to the right, you can look at the zone diameters, resistant to 1 drug, erythromycin. So this analysis has 3 outputs, as you can see on the slide. There's the detailed signals, the summary signals, and the isolate listing. The detailed signals and the signal summary, they look very similar in what I just showed you. I want to show you what the difference is, and I don't think I showed this on the last call. I'm going to click on options. The difference doesn't happen. There's no difference when you do retrospective. The difference is when you do simulated prospective. Instead of putting a threshold of 365, that's not going to show me any difference. I'm going to put something absurdly low, 7 days. 7 days is not scientifically meaningful, but I'm only showing you 1 month of data. So I'm just putting something very low to show you the difference between the detailed report and the summary report. Click OK, click OK. Click on Begin Analysis, and in the bottom, you'll see each of the days of the month. It just ran StatScan 31 times. And here you see there are 4 clusters. There are 4 clusters, but there are 5 rows. If you look at column 1, well, you column 2, signal 1, 2, 3, 4, 5. But if you look at column 1, you have cluster 1, cluster 2, cluster 3, cluster 3 again. And then cluster 4. The reason is that this cluster generated a signal twice. It generated a signal on January 18th, and there were 3 people involved. And then it generated another signal on the 19th with 2 more people. So what's happening is this is a cluster that evolved. It found the cluster on January 18th when the cluster had 3 people. It found the cluster again 1 day later with 2 additional people. So the number of people has gone up. So it's the same cluster, it's cluster number 3, but it found this cluster a few times. So that's very interesting because it's related to also your ability to intervene. This was not a cluster that came and went on its own. It came, it grew, maybe it grew more. Anytime you see multiple signals for a cluster, that suggests an opportunity for you to intervene and to try to control this outbreak before it gets out of control. So the detailed report that I'm showing you has 1 row for each of the signals. And there was 1 signal on the 18th and a different signal on the 19th. I'm going to click on Continue, and now it summarizes it, and those 2 rows get combined together. It was detected on, first signal was January 18th, second signal was January 19th. If I move over to the right, the number of observed at first was 3 people. Number of observed maximum was 5 people. So the 2 tables are basically the same, except here there's 1 row for each cluster, and the other one there is 1 row for each signal. And sometimes a cluster has 1 signal, but sometimes a cluster has multiple signals, suggesting that the cluster has been growing. So that's the difference between the detailed report and the summary report. I will now click on Continue, and that shows me part 3, which is the listing of the people. So for example, here under cluster 3, I'm sorry, cluster, which one is it? Yeah, under cluster 3, let's see, these are the 5 people. It started off with these 3 people on the 18th, but then it became these 5 people with the 18th and the 19th. So you can always get the details of the room numbers, the zone diameters, the other details about specimen type. And this particular cluster, 4 of them were blood. Whenever you have blood involved, that's important. And 1 of them was a urine. Because in an outbreak, different people will end up with different diseases. So we just completed the first hour. I'm just taking track of the time. So I'll continue out of here. Let me go back to the PowerPoint. Cluster outbreak to part 2. So all of that was officially the review, but some of that was new material. Advanced data preparation. I've just decided I'm going to change this order of 2 sections. This section we're going to come back to. It's about cleaning data files in multiple steps. Very important. I was planning on talking about this first, but it's only a few slides. But because we're in the middle of WHONET analyses, I think it's more interesting if I talk about some of the advanced parameters for analysis. So whenever we talk about StatsCan, there are 2 parts. There's data cleaning and data analysis. So everything I talked about today was mostly about the data analysis. So I'm just going to continue on that before I go back to the discussion of data cleaning. Of course, the analysis part is more interesting anyway. So for advanced parameters. So StatsCan was made for space and time scan analysis. But by space, what was originally intended was latitude and longitude, miles, kilometers, true physical locations. But the author of the software, Martin Koldorf, a biostatistician, realized that kilometers and miles and meters did not really mean anything inside of the hospital. So we needed Instead of using parameters like latitude and longitude in kilometers, we use non-parametric details such as the medical wards and the medical services. And we can use laboratory names and city names. So of course, with laboratories, you can use the latitude, longitude. City names, you can use the latitude and longitude. But we found that even if you can use latitude and longitude, you have greater flexibility if you treat them without the true distance. And I will give some examples of that. So after including the non-parametric examples like 5 north, 3 south, neonatal intensive care unit, he went a step further to allow groupings. With true distance, he could use kilometers, 5 kilometers, 10 kilometers, 20 kilometers, but to do something in a hospital, he did it in a different way. For example, in my hospital, we have 4 units, 5A, 5B, 5C, 5D. It's a tower. So we consider those as 4 different units. But we also consider them as one unit, which is the 5th floor. So with SaTScan, you do have the ability to look at each unit separately or groups of units. For example, I do want to look at each ICU separately, but I also want to group the ICUs together. Whenever there's an outbreak, it's very easy to cross over to different units that are geographically close or that share the same risk factors. For example, in my own hospital, we group together 6A, 6B, 6C, 6D, and 4A. Why do we do that? Because 4A and the 6th floor is where we do bone marrow transplant. So even though they're not physically all connected, it's the same physicians, the same nurses, the same equipment, and the same patients going back and forth between them. So by having these groupings, we have found a lot of value in improving the interest in our clusters. So for within a hospital, it might be 5th floor, all ICUs, all surgical services, or it might be within a geographic area, all the hospitals from network number 1, all the hospitals from network number 5. And that's useful because geographically they might overlap. But when you have patient transfers and physicians and nurses, they often stay within a network. So here you don't want the latitude and longitude because the network is the more meaningful way to group them together. You might say all laboratories in the eastern area, the chicken farms, the sheep farms. So you can be very flexible with how you define these. So even though we could apply latitude and longitude for some of these, by using these groups, we have greater flexibility in how we decide we want to group them together. For example, in Boston, we have a few healthcare networks that overlap. So for certain things, we'd like to stay within the network, even though geographically we overlap with other networks. So how do we do that? In WHONET, we call that meta location or meta group or meta ward. And what I do is I create a simple text file, and then I tell WHONET how I want the locations to be grouped together. I use the bracket symbol to mark the name of the group. And I'll show you an example that I made for purposes of today's demonstration. Cardiology is going to include cardiology and cardiac surgery. Medicine is going to include Med 1, Med 2, infectious disease, neurology, and oncology. ICUs will be ICU 1, ICU 2, surgical intensive care unit, and I can also put oncology if you feel that's appropriate. I did that just to demonstrate that you don't have to put one location in one group. One location could be in multiple groups. For example, if you have pediatric surgery, you can put that with the pediatric locations because there are risk factors from the other children, or you can also put it in the surgical group because there are risk factors associated with surgery. So I put oncology here to demonstrate that it does not have to be one group. You can put it into different groups. You can also be hierarchical. In my own hospital, we have one group for all of the different obstetrical services. We have a different group for all of the different gynecological services. And then we have a higher level group, which is all the obstetric and gynecological services. So you can be very creative in how you group these together. You can do this, for example, with geography, the south of the country, the north of the country, province number 1, province number 3. Let's see, and then how do we use it? So I'm going to show you what this file looks like. The file I showed you, I put it into the WHONET folder. I gave it this simple name called Meta Wards. I'm going to open this file up in Notepad. So I just created this manually. There's no fancy software. I simply went, and I could put more if I want. I could say, for example, surgery is equal to surgery and, I don't know, ophthalmology, plastic surgery. So you can be very creative in putting these together. I'm not going to save that because those are not the correct codes. I don't remember all the codes. Good. So this file exists. I made this file with Notepad. At the present time, WHONET does not allow you to make this file, but it is an easy file to make on your own. In the future, maybe we'll make a little text editor where you can type these things in yourself. So that file has valuable information about how these locations can be grouped together. How can I use that file? Now I will go back to WHONET. Let me go back to a simpler example. Let me just choose only resistance. I'm sorry, that's not what I meant to say. Only location. I want one variable, which is location. Row 1 should be location. There's no row 2, there's no row 3. There could be, but I just want to show you a simpler example. So I've already done this analysis with you with Staph aureus. If I look for the clusters, it is going to show me well, maybe we didn't do this particular one. That's right, it's doing it simulated perspective. We did something similar to this, but this time we did it with simulated perspective. So here you can see these are two signals for the cardiology Staph aureus cluster. We found this cluster on the 18th. We found this cluster on the 19th. So it went from 3 people up to 5 people. So we have 5 signals, but we only have 3 clusters. These two are both in oncology. We found this cluster on the 16th with 3 people. We found the cluster again with 5 people. Okay, so that's showing how the cluster can be detected on multiple days, demonstrating that it is growing. I'm going to click on continue. Those 5 rows have now been consolidated into 3 rows. I can continue. And here are the people. So I can see all the people associated with signal number 5, all the people associated with signal number 4, etc. So this gives you all of the details. So this is very similar to what we did already. But now how do I introduce the location groupings? I go to options. Here at the bottom, it says additional information location. I can put the latitude and longitude if I have that information. We had a project with one of the US states, and we did put the true latitude and longitude of each of the hospitals. But in this example, even in that state, we did it with latitude, longitude, but the results were more interesting when we did it this way. There are different reasons for that, but when you think about distance, inside of a city, 2 kilometers means a lot. There are many hospitals within 2 kilometers of my hospital. But if I go out to the countryside, there's only one hospital every 20 kilometers. So even if you have the latitude and longitude, the meaning of 1 kilometer is very different in a city than it is in a rural setting. So that's why even with true latitude, longitude, when we have it, we often still prefer to group them by location groupings. So file name, this is the key portion. I say code groups, browse, and it's in a different folder. It is here. And let me go to MedAwards. That's the file I created in Notepad. Click on open. And now WHONET knows where to find the information. I click on OK. I click on OK. I click on begin analysis. Lower left, it is marching through the database. And what you can see here is the second cluster is cluster number 2 is cardiology. That one is unchanged. It was found on the 18th with 3 people. It went to the 19th with 5 people. So that second cluster, cluster number 2, has not really changed. The cluster number 1 has changed. It says, you know, I found a cluster before with medicine, but here I am grouping together infectious disease and medicine. So it's in medicine generally, and more specifically, it's in 2 of the units of medicine, infectious disease. And that's the detailed report. This is the summary report where it's combined into 2 rows. and continue, here it's showing me all those people. And if I look at cluster, this cluster here, signal number 1, you see 2 of them. Well, if I look at all these, some of them were in medicine and some of them were infectious diseases. So it made sense. It improved cluster detection by bringing them together. I'm going to click on continue. Let me click on Pseudomonas. I don't have any, it's only 1 month of data, so I didn't spend a lot of time looking for very interesting examples. Okay, there's no meta location there. It's just a single location called neurology. I did find another example, but I do forget which organism it was. Let me go to Klebsiella pneumonia. No, that's just so here, as you can see, these clusters are found at the individual unit level. I'm going to go back to the Staph aureus because that was a nice example. Go back to Staphylococcus aureus. So sometimes it is better to look at the individual unit, like here, cardiology, whereas here it's better to look at the group of them. So SaTScan is saying, well, I've looked at it both ways. This is what I find is most statistically unusual. I will click on continue. That's the detailed report. This is the summary report. And again, the listing of the people and their locations. And as you can see, it's a mixture of medicine and infectious diseases. Let me go back to the PowerPoint. Actually, I think I might have finished that. Good. Point here, I'm going to do this now. As I said, I like to make macros. So I'm going to go to macros here. I'm going to call it new macro. I'm going to call this cluster detection by meta ward for Staph aureus. Save. Save again. I haven't spent much time showing you what a macro looks like, but they're very basic, very simple. If I click here simply on the word edit, it simply says, okay, that's the name of your laboratory. You want to do cluster detection by ward and by date, first per patient, space-time permutation, p-value threshold of 0.2, recurrence interval threshold of 7, additional information, Staph aureus, the 1 data file, and some alerts here. So you don't need to understand this, but also if you look at it, it's also very straightforward. It's simply telling you what options are selected on the screen. I can see that here inside of WHONET. I can also do that here in the WHONET macros folder. Look at the most recent macro. So cluster detection by meta ward for Staph aureus. I can open it here, and it's the same thing I just showed you inside of WHONET. It's the same thing. You can visualize it either place. But I'm going to do something special now. I'm going to make a copy of this. And I'm going to change the name, many organisms. Okay. When I open this up, well, the first row still says Staph aureus, so I do need to change that for many organisms. Okay. So far I haven't done anything interesting. I'm going to close, close, close. I've got a lot of things open. Close, 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 close. Okay. This is the one that I want. So far I haven't changed anything. I made a macro for Staph aureus with meta wards, and I made a copy, and then I just changed the name of the copy. I'm going to go back to my PowerPoint, and there's a feature here called begin analysis. I can manually edit the macro and type in begin analysis, where you can want one analysis to end and the next analysis to start. It's an undocumented feature. Unfortunately, we don't have an obvious place to put it on the screen, but it's extremely valuable, and I will show you why. So the usual interactive WHONET will only recognize the first one, so the Staph aureus in this example. But for quick analysis, WHONET will do each of the organisms that you say. For example, I'm back now in Notepad. It says organism Staph aureus here. I'm just going to move it at the bottom just to clarify. I don't have to, but to make the point easier, I'm going to say organism equals Staph aureus at the bottom. If I run this macro now, it's exactly what I just showed you. I have not yet made any changes. If I say here begin analysis, I also haven't made any changes. That's not going to change anything. But now this is the exciting part. I'm going to put this many times. And I'm going to put here E. coli, Pseudomonas aeruginosa, Klebsiella pneumonia, I don't know, Staph coagulus negative, Enterococcus. So, and that's why I call this many organisms. I'm going to save this. I'm going to exit out of this. And if I open that macro for many organisms and I load it, it's only smart enough to remember the first one. So if I run this, it's only going to do the Staph aureus and ignore the other pathogens. So that's not interesting. It just is the same as what I showed you before. On this particular screen, it only shows me the first one. But I'm now going to switch out of data analysis and go to data analysis, quick analysis. And I'm going to go to user defined. This was the subject of one of our webinars back, I think, in November or October. I don't remember which. I think it was October. User defined. I want to make, for example, a new report. And I can say I want daily cluster detection. That's the name of the report. And a report is simply a collection of macros. And I want this one report to do this one macro. Save. Save again. Exit. So now I have a daily cluster report. And I can choose my 1 month of sample data. I say OK. And I can click on begin analysis. First, it's going to do the Staph aureus. You just saw this, cardiology and medicine. The detailed report, the summary report, and the listing of the Staph aureus. Organism number 1 is now finished. It's now doing organism number 2. E. coli, it says it in the top left here. E. coli, 71 isolates. So oncology, SICU. So there's no meta location. Everything here was found by individual unit. That is E. coli details, E. coli summary, E. coli list. And then it continues. And now it's Pseudomonas, 1 cluster, 1 summary, the 2 people. I think it's now going to do the Klebsiella pneumonia, detail, summary, listing. I think it's now going to do the Enterococcus or coagulase negative staph, I forget. Yeah, coagulase negative staph, detail, summary, listing. And it looked for Enterococcus, but it didn't find, oh, no, it is here. So here's the Enterococcus. And again, everything was a cluster by an individual unit. There's no brackets here, so it did not incorporate the meta stuff. The details, the summary for Enterococcus, and the listing. So you can see how valuable it is to use that feature called begin analysis, because I made the 1 macro, but I could have the 1 macro run repeatedly, this organism, this organism, this organism. Or I can do this laboratory, this laboratory, this laboratory. So if you're a national data manager, the begin analysis feature can allow you to do a lot of different kinds of analyses in a more automatic way. You don't have to make 1 macro, 1 set of macros for each lab. You can have 1 macro that you apply to 20 different laboratories. You can use that for the cluster detection work that I've been talking about today, but you can do it for antibiograms or any of the other alerts as well. I just saw the results on the screen. I'm now going to export the results to Excel. So it's now looking for clusters in Staph aureus. I might interrupt it if it takes too long. It's doing the Staph aureus. It is now doing the E. coli, I think. I put too many organisms. I think it's doing the Pseudomonas now. It's now doing, I think, the Klebsiella. Now doing the coagulase negative staph. And now it's doing the Enterococcus. And that's the last, and then it's finished. It's now going to create an Excel file, and it asked me if I want to look at the Excel file. Are you done? Yes. And the file is now opening. And here you see the same results I showed you on the screen, but now they're in Excel. And at the bottom, you see cluster details. So here I see Staph aureus, details, summary, list. That's sheet 1, 2, 3. And then I have sheet 4, 5, and 6, E. coli. So I have 3 sheets. I have 3 sheets for Pseudomonas, 3 sheets for Klebsiella, 3 sheets for coagulus negative staph, 3 sheets for Enterococcus, and that's it. So instead of being here on the screen, you can just save it to a file. It's a lot of Excel tabs. It's a lot of Excel sheets. So personally, what I do is I don't do that. I send it to Access, and then it just integrates it into just one big table. Just more convenient that way. But if you start getting into this, please reach out to us for tips on how to make your life easier. So I'm going to go back to the PowerPoint. So just to repeat, this is not specific for cluster detection, but it was a good time to talk about it. Just take the macro that you made, type the word begin analysis, and then you can make modifications below it. Change the organism, change the data files, change the laboratory, change from blood to urine. So there's a lot you can do by having one macro do many things at once, but many things consecutively. Okay. What's the time now? 7:24. I'm in Bangladesh, as I mentioned earlier. Okay, because I'm on the subject of analyses, I'll talk more about this, and then I'll go back to the advanced data cleaning. So strategies for assessment and validation of statistical signals. SaTScan is very good at generating numbers for you, but are they true outbreaks or not true outbreaks? We don't have a good answer to that. So I'll start off with some retrospective. If I have some data from the last 5 years, there are limitations on how much you can say. There were 5 people in one room 4 years ago. Was that an outbreak? I don't know. It was 4 years ago. So there's limitations on how much we can decide about whether patient clusters represented an outbreak or not. The information is all in the past, so we have limited ability to do further investigations. So one thing that you can do is look at existing infection control reports. We're finishing up a study now with Japan, and the results were very exciting. We had a list of known confirmed outbreaks, and we found every single one of them with our settings except for one. So in terms of finding known confirmed outbreaks, our sensitivity was excellent. Unfortunately, many people do not have these records. They don't remember. There's no logbook. It's in some emails. So if you have existing records in the public health authority or in local infection control, you can compare the WHONET-SaTScan results to that known list, if that known list exists. So if there is a list of known outbreaks, that's an excellent place to start. We can check to see whether the statistical clusters found by WHONET-SaTScan were found by the traditional methods for cluster recognition. If yes, then WHONET-SaTScan successfully found the suspected, investigated, and/or confirmed outbreaks. So it's great when they do match. It just reaffirms that what people can do manually, we can also do statistically. But if there was a known confirmed outbreak and we didn't find it, why didn't we find it? Maybe the numbers were too small. Maybe it just looked like random variation and it was not statistically significant with the threshold that we decided to use. It's also interesting what criteria were used to call it an outbreak. Sometimes if you have 2 people die, it will be called an outbreak, even if the numbers are really not that different. Or if it's in the nursery, maybe it would be called an outbreak, but if it's in a normal medical unit, it won't be called an outbreak. So if there are known confirmed outbreaks that our algorithms did not find, can we get some reason, some understanding about why we missed it? Start with doing a graph, start with how many patients, etc. Also, if we didn't find it, maybe we can make some adjustments to the algorithms so we could find it better. And that's exactly what we did when we switched from space-time permutation to space-time uniform. We did not find important clusters with our settings that we were using. So we switched, and then we found them very easily. Okay. But after you compare with the known outbreaks, you will then have still a large number of statistical clusters that were found by WHONET-SaTScan, but they did not know about. And that could be a good thing or a bad thing. If they were true outbreaks, that means WHONET-SaTScan is doing a very good job of finding important outbreaks that people were missing. That would be a good thing in terms of the value of the approach. But if they were false positives, that's a bad thing. So one critique of a lot of algorithms for finding clusters is not that they don't find clusters. The problem is they often find too many clusters. And too many clusters, a lot of them will just be simply false positives. So if we found statistical clusters in the database that they were not aware of, we cannot say with certainty whether they were real outbreaks or not. But there is something that you can be a bit more objective about. Was it an outbreak? I don't know. Did I want to be informed? That's also a valid question. If I look at the data, say, I would have wanted to be informed. I did not know in real time. Maybe it was a real outbreak, maybe it wasn't. But yes, I wanted to be informed. You can also ask them, high, medium, low interest. What would you have done? Would you have done outbreak, investigation, cluster cohorting? Would you have done molecular typing? So I can tell you that WHONET-SaTScan will find a large number of statistical clusters that you were not aware of. The question is, did you want to be aware of them? If they're false positive, that's bad because you're getting a lot of extra work without a lot of benefit. But if they're true positives, then that's, of course, interesting. So for retrospective assessment, there's really not a whole lot you can do. You can compare with the known existing records, and you can ask people, would you have wanted to know? What would you have done? But everything is in the past. The better thing, but of course this is much more time consuming and much more expensive, is prospective, and that's what we have been doing with the CDC. In real time, we have the advantage that we can actively seek additional information from patient records. Molecular typing, we can take more screening samples from healthcare workers, from other patients, from the environment. So there's some core questions. Are the statistical signals generated by WHONET-SaTScan clinically and epidemiologically relevant? Were they worth notifying? Secondly, after you do the investigation, were they real outbreaks or not? Thirdly, if they were real outbreaks, did people respond and do something? If they didn't do anything, then it doesn't really help for us to alert them if they're not going to take action. So did they take any action? And then finally, did the actions have any beneficial impact? What was the cause of the outbreak? Did they find it? Can they prevent further spread? Can they more appropriately manage the patients that are potentially a part of the outbreak? Hopefully, you'll have shorter outbreaks, fewer patients, and better outcomes. And especially over time, maybe at the beginning, you'll find more outbreaks because it's doing a better job of finding outbreaks. But as you start to understand the reasons for the outbreaks, hopefully you can start to introduce preventive measures going forward. Good. Good. Optimization of parameters. I mentioned we tried 30 days, we tried 60 days, we tried 180 days. So how do you decide what parameters to use? If we change the various analysis details, does it make a small or a big impact on the conclusions? If the impact is very small, that's kind of a good thing. If I say 30 days, 60 days, 90 days, most of the clusters will be found with all of the parameter sets. So what you will generally find is it makes a difference, but it doesn't make a big difference. In which case, just choose the one that looks the best, and I'll come to that further down. So if the impact of different parameter settings is small, that's just reassuring. It means it doesn't, if the conclusions depend too much on your parameter setting, you really have to question about the validity of the conclusions. It's just too set. If I try this, I get very different conclusions. That's not good scientifically. What you would want is the different parameters make a small difference, and maybe one is a little bit better than the other. Okay? So if the impact is small, that's great. It's what we call robustness analysis. It makes a difference, but it doesn't make a big difference. On the other hand, if the impact is big, then we want to try to understand why. Should I be using 7 days or 180 days? If you're looking for outbreaks of Ebola and COVID, you want a nice short time period. If the time period is too long, you have this problem of what we call multiple comparisons, decreasing the statistical power. So sometimes you put the parameters like 30, 60, 90, you'll end up with similar results. But if you put 15 or 300, that's where at the extremes, you start to end up with very different results. So you may not want to go that extreme. So as we change parameters, you will often see that most statistical clusters are consistently detected for all of your parameter settings. And if that's true, you can look at other measures, statistical significance, which one is a higher recurrence interval, which algorithm found it earlier. This algorithm found it on Wednesday, but this algorithm found it on Monday. The Monday algorithm, that would be a benefit. Who found more people, more locations? So it makes a small difference, and just choose the one that gives you the best results. And whenever you change these parameters, what always happens is you'll start to pick up more clusters when you make certain changes, but you'll also start to lose some clusters. And people think, oh, gaining clusters is good. I'm finding more outbreaks. And that's not always the case. As you can see here, if you gain true positives or lose false positives, that's a good thing. You're getting better true cluster detection, and you're getting rid of a lot of background noise. So finding more clusters can be good if they are true clusters. But if you lose true positives, we call that worse sensitivity. Or you gain more false positives and you have worse specificity, that's not a good thing. So of course, we don't, and again, we have the problem, what is a true or a false positive? Prospectively, you have some things you can look at, the molecular typing, the risk factors, screening, other things that you can do. But for retrospective data, is it a true positive, not a true positive? You often don't have a good criterion, but you can look at the level of interest. Yes, I would have been interested. Yes, I would have taken a further look. Yes, I would have sent an investigation team to look. So that's just some general principles. In short, we don't know exactly the best set of parameters. We do think it will be different depending on data volumes and resistance issues and locations and variability. So this is just giving some general principles on how you can apply these things and then decide on your own. So then I did skip a section. Now I'm going to go back to that section. Data preparation. Okay. So I already talked about this slide. So I already skipped over this. Yes, this is where I am. So I'm going to do 3 examples. How can we take a WHONET file and make a smaller WHONET file out of it? Example number 1 has nothing to do with cluster detection. Example 1, I have my large annual WHONET file, and I have a colleague at another organization who's doing a research project on Streptococcus pneumonia in blood. And he says, John, are you willing to give me your Streptococcus pneumonia data in blood? But I don't want the patient names. I just want the details. I don't want the patient level. I don't want dates of birth. I don't want patient names. So I say, well, yeah, I'm happy to share data, but I don't want to share all of my data. I just want to share what's part of our agreement. And typically you would need a legal agreement, a data sharing agreement, a business associate agreement, a data use agreement, some way where I am permitted legally to share my data with you. So example number 1, I'm going to take a large WHONET file, excuse me, and make a small WHONET file out of it. I know I have to see if strep pneumonia, we might not have enough isolates, but I will see. So data analysis, and I accidentally closed my PowerPoint, but I want the positive bloods for Streptococcus pneumonia. So I can go to analysis type. That kind of analysis is called isolate listing and summary. Right now, I don't care about the summary. I just want the list. The person didn't ask me to count it. The person just asked me for the list. So all I need is the list here. I can put if the person wants the zone diameters, I will do this, or the MIC values. If the person only wants the RIS interpretations, then I can choose the second option, but I'll choose the first option to give them the richest detail. So I want a listing with the measurements, and I say, okay. Streptococcus pneumonia, okay. 1 month of sample data, okay. Isolates, so isolates, I'm here in this section, put isolate filters. I go to isolates, and I go to specimen type, and I will put blood. Okay, okay, and I'll do begin analysis, and I hope I have some. Good, yes. In this small 1 month of data, I have 5 patients with Streptococcus pneumonia in blood. From the left, I do see that it's 5 different people. But, he asked for the whole list. I don't have to remove repeat isolates. If he wants the full list, I'll give the person the full list. Here you can see the zone diameters. Or if I choose test interpretations, now I see the interpretations if the person only wants the interpretations. The scientists with good IT skills will want the measurements. But for people who just want like pharmacy or other things, they prefer the interpretation. It's just easier for them to work with. Excuse me. So this analysis is basically introductory WHONET. We haven't done anything different here. It's a list of strep pneumonia in blood with the interpretations. The new thing is I don't want to send it to the screen. I can send it to a WHONET file. WHONET DBase, which is our old structure, or WHONET SQLite. That's what I'm going to do. And I'm going to call this, I'll call it test because that's the name of the laboratory. SPN, that's the WHONET code. Blood. And that's it. As you can see, it's going to go to the output folder in this particular, and that's fine, but I'm going to put in the data folder just to keep all the data files together. So instead of going to the screen, when I go to the screen, this is what you see. But I don't want it to send it to the screen. I want it to send it to a WHONET file called WHONET data, test, SPN, blood, SQLite, begin analysis. It's now finished. And then when I go to Windows, WHONET data, here's the file, test strep pneumonia blood. And you can see the original file is right here. The original file was 164 kilobytes. After doing the strep pneumonia blood, it's only 20 kilobytes. So this file has exactly what they asked for. However, I did forget something. This file might have the patient names. So I forgot to do one step. So to do that, I can go to analysis type. Oh, it's not on the screen. We moved it. Yeah, there's a feature here called options. I don't go here very often, but when I go to options, there's an option for combining DISC MIC test, which is very useful, especially for National Data Manager. The second option is not very useful, but somebody asked for it. That's why I put it in. But this option here is encrypt patient information. So it's an important topic. We did not discuss it on previous webinars. I'm going to go to configuration. And automatically, WHONET is going to delete the patient's first and last name. WHONET is not going to change the organism. WHONET is not going to change the bacteria. WHONET is not going to change the zone diameters. So most of the thing is not going to change. But the specimen number, it will encrypt. The name, it will delete. The identification number, it will encrypt. You can also move the dates around. I don't want to tell you the exact date. That's a little too confidential, especially if there's an outbreak involved. So WHONET has a lot of ability for you to decide what I want to share with the person and what I don't. So in this particular case, I'm just going to accept the default options. And I'm going to say, yes, I want to encrypt the information. And now when I begin the analysis, I will replace the version that I already created. And now this new version of the file, the names and the dates of birth have all been deleted. The identification numbers have been scrambled. So I'm going to go back to my PowerPoint, which I accidentally closed. So what I just showed you has nothing specifically to do with cluster detection, but it is a common need where you have a collaborator and you don't want to share all of the details with your collaborator. You just want to share certain details. So I've just done example number 1, sharing a filtered subset of strep pneumonia in blood and remove. And then I just take that file, that new SQLite file, and I send that file to my collaborator. That's example number 1. Example number 2, WHONET has nice options for selecting an isolate that's blood and outpatient and female and in this age group. And. WHONET does not have trouble with that. Or I can say, I want bacteria that are resistant to this, or this, or this, or this. WHONET has no trouble with that. The problem is if you're trying to mix your Ns and your Ors, I want resistant to imipenem or meropenem to get my CRE, but then I want it to be resistant to nitrofurantoin. So that's a second level filtering. So this needs 2 steps. So I'll show this, and then I'll go to the cluster detection example, which is example number 3. So number 2, how do I do that? I would like all of the CRE first, and that's step number 1. I think I actually have a slide on it. Yes. So number 1, we did that together. Create a WHONET file, go to data analysis, through strep pneumonia, blood, encryption, run the analysis on the screen first to make sure it looks correct and you didn't forget to get rid of the patient names. If everything looks good, then save that as a new WHONET file, and then send this file with a secure mechanism, a secure email, a web portal, put a password or something. And that can be the subject of a different webinar about recommendations we have for improving security when you're trying to send files, but that's a different topic. So that was example number 1. Example number 2, create a list of isolates that are non-susceptible to imipenem or meropenem, but resistant to gentamicin. In fact, I'm going to do nitrofurantoin. The problem with my 1 month of sample data is I wasn't finding anything, but this example that I will show you does work. So we're going to do this in 2 steps that you see below. First, we're going to create a file that has all of the CRE. So that's what I will do first. That's what I will start with. So I want to do this on the screen. I always like to see the screen first just so I can double check that it's what I want. Isolates, clear all criteria. Do you want to clear all the criteria? I'm just erasing, the blood isolate criterion that I just had. I click on OK. Strep pneumonia, no, let me clear the list. Organism groups, I want all Enterobacteriaceae. And Adam, before we release WHONET 2024, let's change that to all Enterobacterales to match the updated nomenclature preferences. All Enterobacteriaceae, okay. So right now, if I do this list, it's going to give me all the Enterobacterales. There are 186 of them, okay? Continue. But now I just want the imipenem and meropenem resistant ones. So I go to isolates, I find imipenem, and I say imipenem non-susceptible, meropenem non-susceptible. I was going to do this demonstration with resistant, but there weren't any resistant ones. So that's why I'm doing non-susceptible. So it includes the I category. So I have imipenem non-susceptible and meropenem non-susceptible. And when I run this, it's not going to find anything. Why is it not finding anything? Because it's looking for bacteria that are not susceptible to imipenem and meropenem. But they didn't test both drugs. They tested one or the other. So none of the isolates were tested against both. So WHONET by default says include isolates that satisfy all of the selection criteria. I don't want all. I just want some of the selection criteria. I say, OK. I say begin analysis. So this is a list. There are 31 of these for all of the Enterobacterales that are resistant to imipenem or resistant to meropenem. I will click on continue. So that's a list on the screen of all of the CRE. And I'd like to save that as a WHONET SQLite file. And what name do I want to give it? No, I don't want to call it strep pneumonia from blood. Let me call this CRE. Begin the analysis. So what I just showed you on the screen is now its own data file. I can go to data files. It's right here. I can remove the original file. I can click on OK. I can remove the selection criteria, clear all criteria. Yes. OK. Let me do this on the screen again. Begin analysis. So what you see here is a file, and this file only has 31 records in it. So this file has all of the CRE. So that was step number 1. Step number 2 is I want to look at isolates that are non-susceptible to nitrofurantoin. I tried with gentamicin, but all of them were susceptible, so that was not an interesting example. So let me say here, isolates, nitrofurantoin, non-susceptible. Okay, begin. So now what you see is everything here is resistant or non-susceptible to either imipenem or meropenem. And it is also non-susceptible to nitrofurantoin, as you can see, R's and I's. So let me go back to the slide. So this is an example where I was not able to export this as one step. I had to do two steps. Step number one, make CRE file. Step number two, analyze the CRE file and just look for gentamicin or nitrofurantoin non-susceptible. So that's a different example where I'm taking a large WHONET file and I'm making a series of smaller WHONET files. And now I'm going to number 3. Select patients whose first isolates are on hospital day 3 and later. Okay, this one's a bit more complicated because our goal is, for example, to find inpatient clusters of MRSA. Some people try to do this as one step. They say, please show me MRSA first on the inpatient unit. And they do this as one step, but they don't get what they think they're going to get. Just a short example. Let's say we have 2 isolates from the same person. Isolate number 1 is 5 days before hospitalization. Isolate number 2 is MRSA from 5 days after hospitalization. If you do this as a one-step filtering, WHONET will give you isolate number 2. It will show you the patient's first isolate on hospital day 3 and later. The problem is this patient already had MRSA as an outpatient, so I really don't want this patient in the analysis. They had MRSA before they got to the hospitalization. So one-step filtering, this patient will be included. Not their outpatient one, but their inpatient one. But I really just want to exclude this patient completely because they had our MRSA before they got there. And that's why we have to do this as 2 steps. Create a filter with first isolates, and then look to see if the first isolate happened on hospital day 3 or later. So let me see how to do that. And I'm going to do continue. First, I will change the organism to Staph aureus. Then I will change the nitrofurantoin non-susceptible to cefoxitin. And resistant is fine for MRSA. Okay. And I want to analyze the original data file that has everything. Let me get rid of the CRE file. Okay. And right now it's all of the isolates. Okay. So right now, oh, and I still have the nitrofurantoin. I forgot to get rid of that. Let me go down until I find the nitrofurantoin. Let me clear this criterion. It's now gone. So show me a list of all of the MRSA. And there they are, all of the different MRSA. Okay. Continue. I don't see any repeats here, but in general, there would be some repeats. So the first thing that I want to do is I want by patient first isolate only, maybe with antibiotic results because we need the oxacillin, cefoxitin. Okay. So here we see all of the first MRSAs. If you look at the location, some of them are in outpatient, some of them are ICU, some of them are oncology. So these are everybody's first isolate of MRSA. Sometimes it's an inpatient, sometimes it's an outpatient. I'm going to click on continue. And I'm going to save this as a new WHONET file. This new WHONET file is going to be called Test Laboratory MRSA. Not only that, it's first. These are the first isolates. It's everybody's first isolate. Now that this new file exists, that new file will become the input for the next step. So I can remove the isolate filters because I've already applied it. I can put this back on the screen so I can see what I'm doing. I can begin the analysis, and now I'm simply seeing that this file has 10 MRSA in it. Some are inpatient, some are outpatient. I'm going to click on continue. Step 2, I'm going to go to isolates, and I'm going to go to a field here called hospital day, just immediately following date of admission. If you have date of admission, great, then we can use the date of admission. If you don't have it, we use location type to separate inpatient from outpatient. But if you have the hospital day, WHONET calculates it automatically from date of admission. If you have the date of admission, then I can go to hospital day and I can say, please show me isolates that are on hospital day 3 and later. I click on OK, I click OK, I click on begin analysis. So as you can see here, these are all of the isolates with first MRSA that happened on hospital day 3 and later. You cannot see the date of admission right now, but there's a column here, an option called show hidden columns. I want to show the hidden columns. And if I scroll over to the right, here you see the date of admission. So here the date of admission was the 4th of January, and the specimen date was the 13th of January. So this was several days into hospitalization. This is from the 27th of December, and the admission date was the end of December, and the specimen date was the 9th of January. So out of all of the isolates of MRSA, these were first isolates in the hospitalized patient on hospital day 3 and later. And then this is the file that I would give to SaTScan. So I've cleaned it up. I can add in or remove the surveillance cultures. I can put the CRE. There's a lot of filtering I can do. Let me go back to the PowerPoint. Step number 1, create a file for the MRSA. Step 2, look for those isolates on hospital day 3 and later. And I just did that. And so that's the end of that. And I can go back to I wasn't hoping to be so close to time, but thank you for your time. I will stop sharing my screen. It's always hard to know how much I can fit in, and sometimes I try to put in more than really fits into the time, but I hope it was useful for you. Adam, can you just guide me on the chat questions? Oh, also feel free to drop off the call. Everything will be available online. I know that with your time zones and your daily work, many of you are busy, but I'm happy to stay on. I've got nothing to do. It's at nighttime here in Bangladesh. I'll go to dinner afterwards. Adam, where should I start?
Hi, John. I don't think we've had too many questions so far. You could just quickly scroll through there. Certainly, if anyone has any questions, now would be a great time to type them into the chat so we can try to include them.
The first question, I think they already got their answer. Buenos días. Will the conference be in English? Yes, the conference. La conferencia está ya en inglés. Yo me refiero bastante español, pero la presentación es en inglés de hoy. So I can give these kinds of webinars in Spanish or French, and we can do that maybe other times in collaboration with PAHO or AFRO or other groups. Next question. I already have a small question. Will the recording of the session be subtitled in different languages? The first one, yes. We did about 20 languages. It is very time consuming. It's a lot of automatic translations. And when I went through, sometimes they're good, sometimes they're bad. The intent was yes, but we are also trying to do our WHONET training course. And between the two, I want to translate the training course materials first. So the idea is eventually to have subtitles for these presentations as well. Okay. If the conference is in English, will the subtitles later be in various languages? So that's the same question. Okay. Great, thanks. Does confidence interval matter in interpreting p-value? Not exactly. WHONET only calculates confidence intervals for like percent resistant. You know, for example, the observed percent resistance is 20% resistant. With a confidence interval, maybe 18 to 22% resistant. So we mostly use confidence intervals when we want to compare the results for two antibiotics. So for p-values, no, we do not use it for cluster detection. The smaller the p-value, the more statistically unusual it is. Maybe outbreak, maybe contamination. So no, we don't use that. Sometimes people pay a lot of attention to confidence intervals on antibiograms. When they do that, I just remind them, the biggest problem is not the confidence interval. The biggest problem is the bias. When you're taking samples from treatment failures, ICU patients, the confidence interval isn't the problem. The problem is the data are very biased. And that will be a subject of our antibiogram webinar. And then from Peru, thank you for that. Thank you for the comment. Okay, the recurrence interval, Adam has provided the comment. The recurrence interval is another way to think about the p-value. The recurrence interval is 1 divided by the p-value, correct? So p-value 0.05 corresponds to 20 days. P-value of 0.001, 1,000 days. So that's all correct. And you could use either, but as I mentioned during the session, the recurrence interval has two benefits, is that it's just more meaningful to non-statisticians. If you tell somebody this is like a once in a 500-day event, you know, let me not say 500, 700 days. 700 days is about 2 years. It's a once in a 2-year event that's easier for people to understand. And the other advantage of the recurrence interval is when people think about p-values, they think about 0.05, which is fine if you do the experiment once. But if you're looking for outbreaks every day, you're going to have a p-value of 0.05 approximately every 20 days. So about every 3 weeks. Okay, there's another question. How to make StatScan to work with old files. Since when do analysis, we have a type of lab configuration, but the old was created with another lab config. As long as the important columns overlap, then it doesn't matter. As long as they're testing, the main thing, of course, is the antibiotics. So it's not a problem combining old data with new data. All of the patient and sample fields should be the same. You just want to look at the antibiotics. So one thing I did not talk about a lot today was the multi-drug resistance patterns. I showed some examples with the penicillin and erythromycin. Multi-drug resistance was the topic of one of our earlier webinars. So I didn't talk as much about it today. But for outbreak detection, I did notice Maro's here from Italy, and we're doing a project with them. And it's very important to choose meaningful antibiotics to get meaningful results for outbreak detection. And we discussed that a few months ago, and I only mentioned it a little bit today. Thank you.